Good afternoon, everybody. I had to step into somebody else's role. This is, there are some facts all of us have to know. Single strand strategy with or without side branch plain balloon appears to be the preferred choice. This is what is the data we all have from multiple trials, and analyzing all the existing results, this is some information we have. Whether it is left main, whether it is normal bifurcation, this is found to be absolutely correct. Provisional stenting single strand strategy does not mean the poor final result, because that is not acceptable. To make it a single strand strategy and compromising on the results is not acceptable. Just like what statement Ajit made or we made about left main stenting, the result is primary aim. Two stent strategy is very reasonable approach in appropriate cases, and it does not mean poor long-term result. When you have to use two stents, you must use it. Don't be hesitant. Ultimately, we need a proper result. Final kissing balloon would be preferable. This is what is the information I have gathered over the years, and this actually forms the conclusion of my presentation also. Let us go now looking at various aspects. Which is preferable, radial or femoral? To me, femoral is preferable because we have more options of the guiding catheters, and larger guiding catheters are easily usable, and sometimes we may have to use 7 French or 8 French. Situations where there are trifurcation, we may have to use 2 guiding. This becomes much easier. I would like to protect all side branches vessels which is more than 2 millimeters, especially if the ostium of the side branch is diseased. Plaque modification, if required, don't hesitate. Use of cutting balloon, use of rod ablator, or any of these newer devices, if it is necessary, be very liberal. Don't try to compromise on preparing the bed to complete a bifurcation case. Now look at Medina 110 and 101, single stent strategy with or without side branch wire kissing balloon if necessary is fine. If it is 011, SKS, though everybody says it's a terrible option, but if it is, if you have interrogated the vessel with an IVUS and proved that the proximal part of the vessel is normal, SK is a very, very reasonable option, and there will be only very small shift in the carina. This is absolutely fine. If the angle is too acute and the shift of the carina is likely to be too long, would prefer a mini crush, crossover technique or a Couloir technique. Because shifting the carina too far into the vessel is not a great option, because long-term results doesn't seem to be great. If it is Medina 111, if the side branch is also large, both vessels have to be wired, certainly yes, and option of two-stent strategy must be thought of, provided both vessels are diseased. And when it is in 111, it is all vessels, all segments are diseased. If side branch is larger than the distal main branch, it is absolutely reasonable to stent into the side branch first and then reaccess the main branch, because the selection of the stent becomes much easier if you do this strategy. This, we only will change the strategy in LAD diagonal if the access to the LAD after the stenting is going to be difficult, then we may change our strategy and do it the other. Let us look at some of the options, some of the cases. This is a patient, 40-year-old, 46-year-old man. Got an ectatic disease, mid-right, and distally also there is some ectasia, and it's a Mercedes sign, typical 111. And you have an ectasia immediately after that into the PLB. What is our option? We have few things to remember. We have to have wire in both vessels. You see the origin of the PDA. Even though PDA is a small vessel, PDA is also an extremely important vessel. Same respect what you would give to LED, you have to give it to PDA also. PLB, large vessels, it's important, all right, but PDA you have to protect. When the angle of the takeoff of the lesion and it is diseased like this, what do? We have to, you see the wiring technique. You have to get the wire into the PDA, PLB first, and then get the second wire also into the PLB with a sharp bend. Try to wire the PDA while we are withdrawing the wire back and try to get it. Which we have done, pre-dilated. And here we are decided to stent the main artery from the RCA to PLB. Here this is very, very reasonable to think that way because both vessels will match in size. We did an IVUS, we found out the vessel size. It was almost 4 millimeter. We selected a 4 millimeter stent and stent into the PLB. You cannot use a 4 millimeter stent in a 2.5 the PDA. So you have only this option. This is after stenting. The PDA has pinched. If we don't have the wire there to straighten that vessel like this, it would be extremely, extremely difficult to rewire this. Because the wire straightens the vessel, we were able to rewire it. And you must, if by any chance this vessel is bending, you can pull that wire in the PDA a little more to make it straighter and rewire and did a kissing balloon. And post-kissing balloon, we have a reasonable result. And we stented the mid-right also and look at the final result with the single stent strategy for the bifurcation. And when we use the dilatation only with the balloon, and be careful, don't exceed too much pressure. If you are getting a reasonable result with a 3 to 5 millimeter, but 5 atmosphere pressure, that would be acceptable. Now, this is a 0-1-1 situation. The proximal vessel is absolutely clean. I was checked. Then we have every reason to consider doing a simultaneous kissing stent, which we are doing it here, and this is the final result. In this situation, this is an excellent option. Let us look at something else. You have a left main trifurcation. Both vessels are large, 3.5 millimeter plus. Both the vessels are diseased from the left main ostium into the ostium. You look at here. So you have to have stent in both. If you're looking at an acute angle like this, if we put a stent in the LAD and then try to put another stent into the circumflex, definitely a significant amount of the stent will be protruding into the left main. You have to crush it. The metal at the carina is going to be very large, 3 layers of stent or more, and it will be technically more challenging. I'm not sure about the result. So what is the decision made? We decided to stent from LAD into circumflex and then do a culotte into the LAD, and this is the final result. When you have an angle like this, it is very reasonable to think of a culotte technique when the proximal vessel is very large. You have another situation. You have a moderately diseased LAD, again left main, diseased proximal circumflex. You look at the distal circumflex vessel. It is, and the NOIM, which is a very reasonably good size, 2.5 to 2.75. If we try to stent this, assuming FFR of circumflex was normal, but if I stent the ostium of the OM, it is going to project into the vessel, and this disease segment is likely to give way, and even after the procedure, when we shift him to the ward, we are likely to get into trouble. So we change our strategy. We go ahead and treat that, decide to preemptively treat with 2 stents. You have 1 stent into the OM, the second stent is already ready. You can do this, or you can do a decay crush. But only thing, when you have an acute angle of 90 degree or more, getting after stenting the OIM and then trying to get another stent into the circumflex, even if you, in the best of hands, you can have the stent hitting against this stent at this junction and not bending down, and technically it could be difficult. So you anticipate that and preempt it. Deploy the stent, you have the other stent already in position, and then pull the balloon back, deploy this stent, and then do a kissing balloon, and this is the final result. So when we look at bifurcation stenting, what you have to decide is ultimately what you have to get. If you can plan it and backwards and get whether it is single stent or two stent, our ultimate aim has to be an absolutely optimal result with no compromise. Once we have this in mind, though data shows the single stent strategy, yes, it is true. It is single stent strategy is better, provided you will get an optimal result. Otherwise, it is not the best. Thank you very much.